शादी भी इसे खत्म कर दिया।
अमित, लाइव कर दिया। बता दे भाई। आपका प्रेजेंटेशन जब आता है ना तो वही याद आता है। स्टेप। आप अपना सिलेक्ट।
इसलिए मैंने नहीं लगाया यहाँ 90 होगा फिर।
ये तो मैंने देखा ही नहीं। ना मैं ये वाली ट्राई करती हूँ। Good morning, everyone. I'm Dr. Priyal, and I'll be presenting the infection control data for the month of September and October. So let's start with the liver ICU. So first of all, the total number of samples that we received was around 655, and we can see in the month of September, the growth rate was around 20%, and in the month of October, the percentage was around 14. Now, coming to the positive sample distribution, we can see that the positivity rate was maximum in blood cultures, followed by respiratory, and followed by the urine cultures. Then coming to the sample-wise distribution. So in blood, we can see in the month of September, the positivity rate was around 21%, and in October, it was around 18%. Similarly, in urine, the positivity rate was similar in both the month of October and September, it was around 12%. Then coming to the respiratory samples, so the BAL and the mini-BAL samples are the predominant respiratory samples that we receive, and the growth rate was almost similar in the month of September as well as October. It was around 26 and 24%. Now, coming to the types of organisms, so we can see that both the months, the gram negatives are the predominant organisms, followed by the gram positive and the fungal isolates. So here we can see that in the month of October, the gram positives have taken precedence over the fungal isolates. So here, this is the organism spectrum for the month of September and October. The blue line shows the month of September, and the red line shows the month of October. So we can see Klebsiella pneumoniae is still the most predominant pathogen in both the months. And here we can see that in Candida is also an important pathogen, but most of these Candida were isolated from urine samples, and especially in patients who had a history of prolonged catheterization. Similarly, for Enterococcus, we can see that it is quite common, but again, Enterococcus, the role of Enterococcus is only there if it is taken from an invasive site in drains and in wound swabs, and in urine, it is more of a colonizer. And amongst the gram-positive, Klebsiella pneumoniae was followed by Acinetobacter baumannii. Now coming to the total positivity rate of the patients. So in the month of September as well as October, it was similar, 33% in September and 30% in the month of October. Now coming to the antibiogram. So this is the antibiogram for the month of September and October. As we can see that colistin has retained its intermediate status, so we can prescribe colistin. The other
Just go back to the previous two slides. You said gram positives are more in October. Did you show us which were the gram positive more?
So amongst the gram positive, the most common one was
Enterococcus.
Yes, sir, Enterococcus. Yes. Then, like I was talking about the antibiogram, so here we can see in the month of September, colistin has, in the month of September for Klebsiella pneumoniae, colistin has retained its intermediate status. And the other options that can be there are fosfomycin and minocycline. So this was the antibiogram that I showed 2 months back. So as you can see, there is no major change in the antibiogram. It's pretty much the same here as well. Here also fosfomycin and minocycline had some role apart from colistin. And amongst all the Klebsiella pneumoniae isolates, ceftriaxone, sulbactam, and EDTA combination tested susceptible for around 94% of the isolates. So now coming to the surgical and the transplant ICU. The total number of samples that we received was around 336, and we can see the growth rate is pretty much similar. So here, what is important to note is that the number of isolates, the difference is just 14 isolates. In terms of percentage, it might look more, but it is because we are collecting data only for 2 months. So the number of significant isolates decreases. The number of isolates that we are using as a denominator is also very less. That is why it's more important to focus on the numbers rather than the percentages. So the most common isolates that we received from surgical and transplant ICU were from blood, uh, followed by urine and respiratory samples. So amongst the blood, in the month of September, there were 33 positive samples, and in the month of October, there were 14 positive samples. Then coming to urine, almost no urinary tract pathogens were isolated in the month of September, and in October, only 3 of them were isolated. Similarly, for respiratory samples in the bowel and mini bowel samples, we can see there's only one sample which was positive in the month of September. In the month of October, it was 3. Now, similarly, here as well, we can see that the gram negatives are the most predominant pathogens, followed by gram positive and fungi, which are quite less. So, again, talking about the organism spectrum, Klebsiella pneumoniae, both for the month of September and October, has predominated. Here, what we did see in surgical ICU, there were many isolates of Elizabeth Kingia. And then amongst other gram negatives, E. coli, and among gram positives, Enterococcus was the common isolate. So the positivity rate for the month of September was around 31% and October 18%. But again, what is important here to note is that it was 13 and 7 in terms of numbers. So this is the antibiogram for the month of September and October for Klebsiella pneumoniae. Again, the antibiogram is pretty much similar to the one that I showed before. Colistin has some role. It has intermediate sensitivity for 77% of the isolates. Phosphomycin and minocycline are the other options. This is very similar to the one that I showed in the month of July and August. Not much change has been there for the last 2-3 months. So now, actually, last time we were told to also include the data for the drain cultures, but the thing is, sir, the samples that are, as you can see, this is an article which clearly states that samples from drains are not representative of the pathogens involved in infections. So whenever we are giving positive cultures for drains, it is more likely to be a colonization. It's very difficult to say just from microbiological cultures whether or not it is a true pathogen. That is why we have not included the data for the drain cultures. So now we'll talk about the average use of reserve antibiotics in phase 1 wards. So this includes all the wards in phase 1. So what's important to note here is that the patient who were on dual reserve antibiotics was around 3 in September, and October, it was around 2. For dual reserve, for patients who were on reserve antibiotics for more than 6 days was around 3 in both the months, and patients who were on reserve antibiotics for more than 10 days were around 3 in September and 1 in October. Then coming to phase 2, similarly, coming to the phase 2 wards, the reserve antibiotic usage was similar. The dual reserve antibiotics used per day was around 5 in September and 4 in October. For patients who were on reserve antibiotics for more than 6 days was around 4 in both September and October. And patients who were on reserve antibiotics for more than 10 days were 2 in both the months. So this is the infection surveillance form that we used to collect all the data, which was shown to you. So this is the hand hygiene compliances. As we can see here, the hand hygiene compliances is least for the doctors, especially in the month of October. It has decreased to around 50%. In the last presentation for the July and August month also, we can see that the least hand hygiene compliances has been from the doctors only. The nurses and GDA, the percentages are acceptable. So this is the hand hygiene observation form through which we collect all the data. This is actually the culture plate of a resident doctor that we received in our lab. As you can see, there's growth of all sorts of organisms, not just the gram positives and the common commensals. We can see gram negatives are also there. So we have advised everyone to follow the hand washing protocols. Now coming to the environmental surveillance for the month of September and October. So we received air samples from around 59 places, out of which less than 50% were satisfactory. So we have advised for fumigation and deep cleaning to be done in the cubicle. All the OT swabs that we received were satisfactory. The hand samples, less than 40% of them were satisfactory. We received around 28, and out of which only 11 samples were satisfactory. So we have advised everyone to follow the hand washing
Where
protocols.
are these water samples taken?
Sir, the water samples are coming from different ICUs and wards and different.
It's not for drinking water, it is for usage of
Sir,
tap water.
Sir, there are drinking water samples as well, and there are samples from the scrub stations as well.
That's totally unacceptable. Water samples are unsatisfactory, is not acceptable. I think you should, is there someone for operations? We should see that hand is okay, air is to be improved, but we can't accept the water samples. So please find out and ask Dr. Vic. No. I mean, we should identify and put a red alert on that area. We should teach those people. Hand samples, of course, all of us should do the exercises better. But no question of water samples. Okay.
Okay, sir.
And we go back to the slide where you said reserve antibiotics in phase 1 and 2, dual. What are those reserve antibiotics being used?
Sir, there's a very long, there's a list of antibiotics, sir. Um,
We have carbapenems, we have antifungals except fluconazole. Then we have for gram-positive ticoplanin. These are the part of reserve antibiotics. So they are not supposed to be used in abundance in the wards. So previously we were presenting even a single reserve antibiotic, but we have removed that column because we accept, okay, sensitivity is not there. So probably they're using one reserve antibiotic, but using more than one reserve antibiotic in patient is in ward. So that is something has to be looked into.
Absolutely.
So we have a patient in SDU. I will not take a name of the patient or the faculty. The patient is on reserve antibiotic of ticoplanin more than 15 days now. 15 days on tico with no evidence of any gram-positive bacteria in 3-4 cultures. So this is what we are seeing routinely. I wish that in future, like we present in our, every we take a lot of efforts. Also, with the residents should also present that what steps they have taken or what improvement they have made. So we presenting every time that this is what the observation is, this is what. So we want in future the residents should also, okay, based on the evidence, we have de-escalated based on the evidence, we have stopped the antibiotic, we improved our hand hygiene compliance. So this is a two-way process. So it is not only going one-way process. We are presenting every second, third month, we are presenting data. And I think maximum presentations here are from microbiology in the past 1 year.
Yeah, I agree with you. I would request we should have a debate as well as discussion in the department or faculty meeting. I request in December the faculty should present in my department how the antibiotic improvement has occurred. The head of the departments may kindly take note. I would also like residents to know it has become common practice Miro Tico. I mean, as if it is a combination. Please do not use ticoplanin as one of the routine antibiotics. So it is, and also meropenem only when it is from outside or some other. We should be very careful on that.
So I would like to understand what kind of a debate or discussion that you want. We can do it, but in my opinion, because you make an effort and it has an impact. When you whatever you say here, I'm sure most of us it has an impact on us. This is how we have to change our practices.
Antibiotic cycling. Easiest thing is antibiotic cycling. So as Sir has said, why we are stuck on Miro and Tico all the time? Why? Why Tico? We are fascinated with Tico. So cycling has to be done. Some kind of reasonable thinking justification has to be done. We should think twice why ticoplanin is being added for all the patients. Why dual antifungals we are giving to a patient? What is the rationale behind it? Is it radiological? Some kind of evidence should be there. So most of the time when we question them, we say patient is having fever. So antibiotic is antipyretic. So this is very strange. Antibiotic is antipyretic we are using. So एक spike eye fever की 100 की रात को सुबह start कर दिया antibiotic. So residents are, I don't know what is the mindset. Are they scared of the faculty or what?
Clinicians are not making mistakes, but tell me the way that we can have this two-way process. I mean, I have not understood how can we have this. If I have to put it in this, how do we do it, sir?
I think his point is valid and repeated hammering is needed and unjudicious use. Yes, if patient is very sick, adding extra antibiotic is all right.
Don't concern me, but you can name the ward. Ask us. I'm okay, and I won't.
We are presenting everything right here. Phase 1, phase 2. If we go beyond that, it become too personal. So we are generalizing it, and we are giving you idea what actually is happening. And we cannot be very, very specific because that become kind of personal. It happened in the past with you, ma'am. You know that.
Because
if I go deeper than this,
Short of a clinical audit is nothing that it was.
yeah, short of clinical audit.
It's very important. Just 10 seconds. Ticoplanin, my suggestion today is only use it if you suspect an MRSA, which is still less than 10%, 8% in Indian population, even the data from ICMR. So please do not add that drug. If you want to add for 2 gram negative coverage, because carbapenem covers most of the gram positives except an MRSA. Is that right? Because yes. So if you want to add second as gram negative in a sick patient, 2 gram negative empirical coverage would be much better outcome. That's my request. That's a general teaching.
Okay.
Reserve antibiotic form is a good tool actually. So if they feel it judicially, then we can present it. Okay, we can use that form that okay in this. So there are various columns. Justification of using reserve antibiotic for more than 10 days. Justification of using 2 reserve antibiotic. If we get that form, we can get a better idea, but nobody's filling it. Nobody's signing it. So we have to chase the consultant faculty to sign it. So if that form is filled judicially, that will give them insight
Antibiotic
as
should
well why
not
they are
be
doing it.
used, antibiotic should not be made available unless the consultant signs. Let this become a practice.
Yes, sir,
Doctor,
this practice be made.
Unless
I do sign in emergency many times, but
I sign it in my ward.
yeah. So
I
should-
sign it and I request unless the reserve antibiotic form is signed by the consultant, the drug will not be issued.
I think that's
we
reasonable.
can take that.
Okay.
We have debated that in past as well. The thing is that in the evening or night, so the resident, we can make
That,
it 20,
that would be
within
an
24
exception,
hours.
Dr. Vikas. Yeah, within next 24 hours. Yeah.
Okay. All right. Thank you.
Thank you, sir.
We have another presentation. Mr. Manoj is there. Manoj में कहीं जा रहा है?
Good morning, respected sir, respected ma'am, to all my seniors, my batchmates, and my juniors. My second thesis presentation is on efficacy of rifaximin versus norfloxacin for secondary prophylaxis of SBP, a randomized controlled trial. Introduction: spontaneous bacterial peritonitis is a key complication of cirrhosis seen in around 30% of in-hospital patients and is associated with a high mortality with an estimated survival of 30 to 50% at 1 year and 25 to 30% at 2 years. The 1 year probability of recurrence is 40 to 70%. Now, the data and recommendations on norfloxacin for secondary prophylaxis of SBP. Treatment with norfloxacin reduced the probability of recurrence of SBP from 68% to 20%. The probability of SBP due to gram-negative bacilli decreased from 60% to 3% when norfloxacin was used for secondary prophylaxis of SBP. Now, it was more effective in the prevention of SBP recurrence due to enterobacteriaceae as compared to placebo or other medications. As per the EASL recommendation, administration of prophylactic norfloxacin is recommended in patients who recover from an episode of SBP. The alternate antibiotics include ciprofloxacin or cotrimoxazole, but evidence is not as strong as that with norfloxacin. The bacterial resistance in SBP on secondary prophylaxis on norfloxacin. Increasing frequency has been noted of bacterial infection of quinolone-resistant microorganism and gram-positive bacteria in cirrhotic patients. Patients on norfloxacin showed more frequent infection by gram-negative bacilli resistant to quinolones and by non-enterococcal streptococci. 52% of the gram-negative bacilli on norfloxacin as compared to 46% with placebo. Benefits of rifaximin versus norfloxacin. Rifaximin is a non-absorbable antibiotic having coverage for both gram-positive and gram-negative bacteria in the gut with low risk of bacterial resistance. It has a good safety profile due to negligible absorption from the gut with minimal systemic effects as compared to norflox. The incidence of new SBP reduced by around 20% with rifaximin as compared to 13% with norflox. These patients also develop fewer episodes of HE compared to norflox. Now, before moving to my study, there were 4 studies that we have seen, out of which the first study was by Praharaj et al. It was an RCT where they had used rifaximin or norfloxacin for secondary prophylaxis. But the primary endpoint was occurrence of SBP at 6 months. The SBP was seen in 7% in the rifaximin arm as compared to 39% in the norfloxacin arm with decreased newer events of hepatic encephalopathy. Gupta et al. In Hepatology 2021, it was a prospective study where they gave rifaximin to one arm and rifaximin along with norfloxacin to another arm for 6 months. The incidence was almost same at 6.7% and 6.2%.
Then the remaining two studies, Shamshia and Madhukar et al., it was both for primary as well as for secondary prophylaxis. They had followed up the patient for 12 months. They noted that 4.7% of patients in the rifaximin arm had SBP had recurrence of SBP at compared to 14% in the Norflox arm. Assam et al. Study where they followed up the patient for 6 months. SBP arm had 14% had SBP in the Norflox arm compared to around 4% in the rifaximin arm. Now, coming to the study, it's an adequately powered randomized control trial is lacking. The hypothesis is rifaximin will be more effective in decreasing the incidence of SBP in patients with cirrhosis and prior episode of SBP. Aim of the study was to study the efficacy and safety of rifaximin versus norfloxacin in preventing incident SBP, preventing non-SBP infection, and improving transplant-free survival in patients with cirrhosis and previous episode of SBP. Primary objective is to study the efficacy of rifaximin versus norfloxacin in preventing incident SBP in patients with cirrhosis and previous episode of SBP within 6 months. The secondary objectives were preventing non-SBP infection, acute kidney injury, hepatic encephalopathy, and improving transplant-free survival. Trial design, it was a single-center, open-label, randomized control trial. The participants' inclusion criteria were age more than 18 years, cirrhosis of any etiology with ascites and a prior SBP. Exclusion criteria included allergy to norfloxacin or rifaximin, recent history of upper GI bleed within 2 weeks, patient with a history of multiple episode of SBP, patients with intolerable or not treatable HCC or the non-hepatic malignancy, on immunosuppression, post-liver transplant, less than 6 months of abdominal surgery, lactating mothers, other causes of ascites like tubercular malignancy, and patients developing SBP and norfloxacin. Now, this was how the study was randomized. Cirrhotic patients with prior incident SBP randomized to either receiving rifaximin 550 twice daily or norfloxacin 400 milligram once daily. The primary endpoint was recurrence of SBP to be noted at 6 months in both the arms, and then subsequently the patient to be followed up till 12 months to note for the secondary endpoint as well as for recurrence of SBP. Primary outcome measure was incidence of recurrence of SBP within 6 months. The secondary outcome measures were incidence of recurrence of SBP within 12 months, incidence of other site infection within 6 and 12 months, incidence of other complications, transplant-free survival, median change in CTP and MELD scores by 6 and 12 months. The expected outcome of the project, after the entire cohort is completed, would be rifaximin is more effective than norfloxacin for secondary prophylaxis of SBP, also associated with decreased bacterial resistance. Now, this was a rescue therapy to be given to patients who develop SBP while they are on secondary prophylaxis, where there will be switch from the rifaximin to norfloxacin arm. Treatment failure was defined as development of SBP at the end of 6 months or 1 year of treatment. Randomization, allocation, concealment, blinding, and implementation was as follows. Assuming incidence of SBP over 6 months is 4% in the rifaximin arm and 15% in the norfloxacin arm, enrollment of 260 cases is to be done, 130 in each arm. With the assumption that with the assumption of a dropout rate of 10%, the total study case will be 280 with 140 in each arm. Random allocation in each arm by block method, taking 10 as the block size. Continuous data was represented by mean plus minus SD. P-value of less than 0.05 was taken as significant, and a survival analysis was done. Now, this was a consort flow. Initially, 100 patients were seen, 20 were excluded out, and then 80 patients were randomized into 2 arms. The first arm of the group 1 was rifaximin, where they received 550 mg BD. The N was 38, and the second arm, they were the rifaximin, the norfloxacin arm, the N was 42. They were followed up at 6 months and 12 months. The baseline characteristics of the patients were as follows. Age was 52 and 50 years in group 1 and group 2. Male was a predominant sex in both the arms, 97% and 85%. Etiology of cirrhosis in the rifaximin arm, the predominant etiology was NASH, whereas in the norfloxacin arm, the predominant etiology was ethanol. Coming to the prognostic scores and grades at baseline.
Go to 60, grade 1, down row, grade 1. Go to 60, grade
Group 1 had total 6, they were total of,
Go to 60, down row, grade 1.
there were total of 6 patients who fulfilled the APASL ACLF criteria with a median score of 9. And there were total of 2 patients with a median score of 10. Cliff grades were 4 had grade 2 in and 2 had grade 3 in the rifaximin arm. 1 each had grade 2 and grade 3 in the norfloxacin arm. Prognostic scores, the median CTP was 10 in group 1, and 10 patients were in median 10 in both the arms. Group in the rifaximin arm, 28 patients were CTP-C and 32 patients were CTP-C in the Norflox arm with a median MELD of 23 and 25. Decompensating events at presentation, 28% had grade 2 and 70% had grade 3 ascites in the rifaximin arm, whereas 26% in the had grade 2 and 73% had grade 3 in the norfloxacin arm. Grade 3 NCAF was present in 70% in the rifaximin arm and 59% in the norfloxacin arm. Coming to the baseline parameters, the baseline characteristics were almost similar between both the groups. At presentation, the hemoglobin was 8 and 9. Total bilirubin was 6 in rifaximin group and 7 in the norfloxacin group, with an albumin of 2.8 in the rifaximin arm and 2.75 in the norfloxacin arm. Creatinine was 1.1 in the rifaximin arm and 1.06 in the norflox arm. Now, ascitic fluid analysis, cultures and antibiotics. The ascitic fluid total cell count, since it was an SBP thesis, the presentation they had high total cell count of 4,000 and 2,000, 2.2, with predominant neutrophil 122 and 80% in the norflox arm. Now coming to blood cultures, blood cultures were positive in 5% in the rifaximin arm and 2.4% in the norflox arm, with 7.9% having urine cultures positive, and ascitic fluid cultures were positive in 7.6%. Antibiotic coverage, meropenem was received in about 78% in the rifaximin arm when they had incident SBP and 70% in the norflox arm, with imipenem tigecycline received in 13% in rifaximin arm and 14% in the norflox arm. They are important, ma'am, because few patients in the cohort also had, along with SBP, they also had pneumonia.
I can't believe 1.9% and 2% it is significant. I think there is a typo. You can't have difference in this. On the other hand, you should use median. Your standard deviation is higher than the mean. It's never used like this.
Echocardiographic parameters between both the group were almost similar. Now coming to the primary endpoint, incidence of recurrence of SBP within 6 months. 26% or 10 patients in group 1 had SBP and 14% or 6 patients in group 2 had recurrence of SBP at 6 months. New events, secondary endpoints, new events at 6 and 12 months.
Go back to the primary, we can't even understand. You're jumping in. So SBP is 10. Where is are these as per protocol or intention to treat?
Per protocol analysis, sir.
So how many completed 6 months?
Sir,
10 out of how many?
38, 21 completed. And
because if you have 42 patients in one arm, how much is this?
20 completed in at 6 months in group 2 and 21 in group 1.
What happened to the others?
So the others, they did not have SBP and a few follow-up were remaining at 6 months.
Because you have written no recurrence in 36. So were they all followed?
Yes, sir.
Okay.
Secondary endpoints, new events at 6 and 12 months. 17 patients in group 1 and group 2 and 3 patients in group 1 and group 2, they had HE during the follow-up period up till 6 months, for which they received intervention. At 12 months, 3 new patients in the group 1 and 4 new patients in group 2 had HE, for which they required conservative management. Now, a median change in MELD and CTP at 6 and 12 months. At baseline, the median MELD was 23 and 25. Follow-up of the patients compared to baseline, 21 patients in group 1 had completed the 6-month period, and 20 patients had completed the 6-month period. The median MELD reduced from 23 to 18 in group 1 and 25 to 22 in group 2. At 12 months, 9 patients completed the entire per protocol analysis, and the median MELD from 6 months, 18, it came down to 16, and from 22, it became 17 in group 2. The CTP also showed a reduction from 10 to 9 and subsequently 7 in group 1, and 10.1 to 9.4 and 7.3 in group 2. Death and transplant-free survival within 12 months, the total death was 16 in group 1, that is the rifaximin arm, and it was 15 in group 2. So in the entire cohort, the total death was 31. This is up till 12 months. Out of which 5 patients underwent transplant, 1 in group 1 and 4 patients in group 2. So the attributable causes were 10. There were 10 deaths due to SBP in group 1, and there were 6 deaths due to SBP in group 2. The other causes of death were non-SBP deaths. There was 4 in the rifaximin arm and 5 in the norfloxacin arm, and urosepsis 4 in the norfloxacin arm and 2 in the rifaximin arm. Transplant-free survival by 6 and 12 months. At 6 months, 59% of the patients survived in rifaximin arm and 66% in the norflox arm, and 48% in the rifaximin arm and 40% in the norflox arm. The total N after after randomization and inclusion was 38 and 42, but the number of events that happened was 17. 1 patient underwent transplant here and 4 patients over here. So the censored or the remaining patient to be followed up is around 55% in the rifaximin arm and 54% in the norfloxacin arm. So this is the split up as follows. At follow-up, out of the 80 patients, 38 were in rifaximin arm. Those patients who reached 6 months was 21, in which the SBP deaths were 10. The non-SBP deaths were 4, and 1 patient underwent transplant within the 6-month period. In the norfloxacin arm, 20 patients out of 42 reached the 6-month follow-up, in which the SBP death was 6, the non-SBP deaths were 4, and transplant was 3. When followed up at 12 months, 9 patients completed the entire 1 year period. Within 12 months, there were 2 non-SBP deaths in the rifaximin arm, and in the norfloxacin arm, there were 5 non-SBP deaths and 1 patient underwent transplant. Survival between both groups, there was no significant difference in survival between the rifaximin and the norfloxacin arm. Transplant-free survival was comparable between groups. At 6 months, it was 59% with rifaximin and 66% with norflox. At 12 months, it was 48 and 40%. No difference in secondary endpoints were noted. To summarize, the baseline characteristics were comparable. At 6 months, SBP recurrence was 26% in the rifaximin arm and 14% in the norflox arm. No significant differences were observed in the transplant-free survival at 6 or 12 months. HE episodes and infection rates were similar. Mortality was predominantly due to SBP and sepsis-related complication. Discussion. In this RCT evaluating rifaximin versus norfloxacin for secondary prophylaxis of SBP in cirrhotic patients with prior SBP, the 6-month SBP recurrence was similar. Now, coming to the interpretation in the context of prior literature. In the prior literature, there have been RCTs and meta-analysis. Elfert has suggested that Elfert et al. In 2016 has suggested that rifaximin reduced 6 months recurrence to 3.9 or around 4% versus 14% with norflox. Whereas Praharaj has said that rifaximin achieved 7% recurrence versus 39% with fewer episodes of HE, though it gave no survival benefit. Now, this has been one of the latest study that has been done by the cohort this cohort is by Silve et al. Bajaj et al. They have suggested that secondary prophylaxis of SBP is associated with higher incidence of non-SBP infection rates, especially UTI, and the secondary prophylaxis is leading to higher SBP recurrence thereafter. Despite prophylaxis intent to reduce SBP recurrence, benefits are negated by resistance, development, and more frequent infection. Neither study showed survival benefit with secondary prophylaxis of SBP. Results support reconsideration of routine secondary SBP prophylaxis in the context of antibiotic resistance, with an emphasis on individualized risk assessment and alternative preventive approaches. Limitation. Small sample size, patients are still being enrolled. In contrast, the NORIF trial demonstrated no survival difference, which may be attributed to high baseline liver disease, local microbiology possibly favoring norfloxacin efficacy, lower quinolone resistance than in the prior RCTs, and open-labeled design and short follow-up for transplant endpoints. The newer options that can be considered includes immunomodulation. Long-term prophylaxis with antibiotics must be weighed against gut microbiota disruption, antibiotic resistance, and increased risk of non-SVP infection. Rifaximin is a preferred option when microbiome preservation and HE control are desired. Adjunct immunomodulation holds promise, but it requires a RCT validation. Future studies may focus on microbiota immune restoration rather than antimicrobial suppression alone.
Dr. Manoj, your comments.
Sir, actually, the premise of this study was that it would be an adequately powered study to determine whether rifaximin was better or not as compared to norfloxacin, as previous studies were of inadequate sample size. But this study turned out to be inadequate sample size, so nothing conclusive can be drawn. Meanwhile, the use of antibiotics as secondary prophylaxis has itself gone into disfavor because of the resistance, and even with Rifux, reports of daptomycin resistance is there if used in long term. And this retrospective study from USA has shown that patients who had received secondary prophylaxis with antibiotics, as compared to those who were not prescribed antibiotics for whatever reason. So patients who were given antibiotics, they had higher recurrence of SVP, higher mortality rates as compared to those who did not receive antibiotic-based secondary. Even in case of primary,
Please keep the mic close to you.
even in the case of primary prophylaxis, also similar data is coming up that patients who receive antibiotics for primary prophylaxis of SVP, they have higher mortality, higher recurrence of SVP. So alternative therapies are required. For example, immune modulation therapy, GCSF, PEG-GCSF, or gut modulation therapies, these are required. So this antibiotic-based primary or secondary prophylaxis itself has lost relevance.
Any other comments?
So
We
there
have
is
a second presentation, just
so
2-3 minutes.
she mentioned antibiotic resistance, and there's something that we are doing in a department. We haven't done it as a research project. We should be doing it. Is that we do a cyclical antibiotics. We give one antibiotic for 3 weeks and then shift over to like if we were giving these two antibiotics, rifaximin for 3 weeks and then we go on to norfloxacin. So somehow we haven't found resistance and problems, but of course it's not a research project.
Manoj as well. Congratulations. So just about the data you presented here. So I thought we've not even gone 50% yet.
50% has been reached.
This is just 50% of what you set out to observe or show. Is that you haven't reached anywhere in this data. That's my understanding if I see the data clearly. No? But just 50% is also not achieved yet. So I think to make a comment on it when you're not achieved 50% of what you set out to be, I think that's not a, you should have just presented it as an interim analysis rather than actually doing it, because you can't conclude anything from this, right? So my query is, what you set out to, what was in your mind when you set it out this RCT? What were you looking at? Were you looking, you don't do the practice in the future, whatever, this trial shows there is looking for better drug for prophylaxis. So what was your mindset in doing this RCT?
Both, sir. We wanted to look whether rifaximin is beneficial and whether initially, sir, as per guidelines also, norfloxacin is recommended. Rifaximin has not yet come out as a definite secondary prophylaxis option for SVP patients. For having SVP once and then they are going home, and then we can consider giving them rifaximin on a long term. Some patients are getting who also had a concomitant underlying.
So in these patients, those patients were also not having HG, but they had SVP, they have recovered and they are body there is higher incidence that they might again have a HVP. The ascites has still not been mobilized. In them, sir, we wanted to see whether rifaximin is better in terms of another episode of SVP or recurrent episodes of SVP and the other beneficial effects of rifaximin as well. So this was the reason, and
Previous RCT, my understanding, previous RCT have not shown any benefit, isn't it, for secondary profile?
they have shown the incidence has come down, but then also the N was very underpowered. It was not, the N was not optimized. It was done on small cohort of patients. But there they have, in one study, they have shown there was no survival benefit. And they have shown that rifaximin was better than Norflox. But it
we can cut it down now, Jashri. We have second presentation. Thank you.
My only suggestion will be when you try and do this type of trial, either N has to be, denominator has to really go big in order to, otherwise this doesn't go anywhere.
So meanwhile, just a last comment. In 2025, the recent published, I think so Dr. Anand Kulkarni has published that short-term rifaximin has no advantage in such cases. So you can try out in the remainder samples on the duration of the rifaximin maybe, because you can have some different results, because this is already published.
What was short term?
Ma'am, I think the 3 months they have taken.
They are giving for more than that. Even.
So you can concentrate on the long-term rifaximin arm.
Their arm was for long term only, Kritika. No, short term. Yeah.
Good morning, everyone. I am Dr. Sahiti. I'm here to present my second thesis titled Ventilator-Induced Diaphragmatic Dysfunction.
You only have 20 minutes, huh, Sahiti, so just briefly.
Ventilator-induced diaphragmatic dysfunction in recipients and donors scheduled for living donor liver transplantation. My faculty supervisor is Deepak Tempe sir, and my co-supervisors are Udit sir, Anil sir, Pamecha sir, and Arora sir. So mechanical ventilation is an essential intervention in the perioperative and critical care settings to ensure adequate gas exchange and to maintain the oxygenation. However, a prolonged period of mechanical ventilation results in significant adverse effects on the respiratory muscle function, particularly the diaphragm muscle. This dysfunction is known as ventilator-induced diaphragmatic dysfunction, which is defined as a loss of diaphragm muscle strength, often after controlled mechanical ventilation. So, the dysfunction has been reported to occur even after ventilation for a duration of as little as 18 hours. So, VADD, it can prolong the weaning time and it may be associated with poor weaning outcomes, ICU, and in-hospital mortality. In cirrhotics, there are multiple factors like ascites, sarcopenia, and pleural effusion, which can exacerbate diaphragm dysfunction. In addition, there can be a direct injury during the surgical procedure by the application of a suprahepatic or a caval clamp, and the crush injury to the phrenic nerve further compromises the diaphragmatic function in recipients undergoing liver transplantation. Recipients of living donor liver transplantation often present with advanced chronic liver disease, which is even associated with a thinner diaphragm compared to healthy donors. So therefore, a bedside diaphragm ultrasound is a non-invasive, reproducible method for evaluating diaphragm thickness, diaphragm excursion, and diaphragm thickening fraction. It can aid in early detection of diaphragm dysfunction and can help guide ventilator strategies and predict weaning outcomes. So, the lacunae in the existing literature, there is a paucity of literature regarding the diaphragm dysfunction in patients undergoing living donor liver transplantation and the effect of mechanical ventilation on diaphragm function. So, our hypothesis is, we hypothesize that the patients undergoing liver transplant surgery are likely to have diaphragm dysfunction. We also hypothesize that elective mechanical ventilation, even for a short duration, that is performed in patients undergoing living donor liver transplantation, can further worsen the diaphragmatic function. So, aims and objectives. Our primary objective was to study the incidence of ventilator-induced diaphragmatic dysfunction in recipients and donors scheduled for living donor liver transplantation. And our secondary objectives include to evaluate the diaphragm function in terms of diaphragm excursion and diaphragm thickening fraction using ultrasound in cirrhotic patients undergoing LDLT and compare it with the healthy donors, and to determine the prevalence of pre-existing diaphragm dysfunction in recipients, and to assess the association of ascites, pleural effusion, and sarcopenia with diaphragm dysfunction. So methodology, it was a prospective observational pilot study that has been performed at Department of Anesthesiology and Critical Care over a period of 18 months. And we included participants aged between 18 to 70 years and recipients who were diagnosed with chronic liver disease and scheduled for living donor liver transplantation. And for the donors, they were healthy adults who have been approved as living liver donors. So exclusion criteria, we have excluded those individuals younger than 18 years or older than 70 years, all pediatric population including children and adolescents, patients with no neuromuscular disorders affecting diaphragm function, and any history of major thoracic or upper abdominal surgery in both donor group as well as in recipient group, and patients undergoing repeat liver transplantation, patients with acute liver failure, patients undergoing emergency transplantation, patient with recent mechanical ventilation history of greater than 48 hours in the past 30 days, and patients who have not provided an informed consent. So sample size collection, as it was a pilot study, all eligible patients who were presenting for living donor liver transplant at the ILBS were included. 100 participants comprising 50 recipients with a chronic liver disease and 50 healthy donor were included. And our methodology included, we had a preoperative assessment, a comprehensive radiological and nutritional assessment was done prior to the surgery, and ascites pleural effusion assessment was done before shifting the patient into the operation theater using a bedside abdominal and thoracic ultrasound. And ascites was graded using the International Ascites Club criteria, and pleural effusion was graded according to British Thoracic Society guidelines. And sarcopenia evaluation, we have evaluated using a skeletal muscle index derived from the CT scan, taking an image at the L3 level, and we have used a software that is 3D Slicer version 5. Using the segment editor module, skeletal muscles at these levels, that is psoas muscle, electrospinal muscle, quadratus lumborum, and abdominal wall muscles, this area were noted, and the cross-sectional area and that was divided by the height square yielded us the skeletal muscle index. So sarcopenia was defined whenever we had an skeletal muscle index less than 42 centimeter per meter square in males and less than 38 centimeter square per meter square in females, according to INASL guidelines. And the diaphragm ultrasound protocol included all the patients, donor as well as recipients, they underwent serial bedside ultrasound at 3 predefined time points, that is T0, T1 and T2. T0, they were preoperatively before shifting the patient into the operation theater, and T1 is 30 minutes after extubation, and T2, 24 hours after extubation. We performed this technique keeping the patient in a second semi-recumbent position, and we examined only the right side of the diaphragm. And the parameters measured, we evaluated the diaphragm thickening fraction, which can be done using a linear transducer, where we can place the linear transducer in the 7th and the 9th intercostal spaces along the just anterior to the mid-axillary line to visualize the zone of apposition. Usually the diaphragm will be identified as a 3-layer structures in the B mode. So this is the B mode, the left diagram, where we can see diaphragm as a 3-layer structure. One is the pleura and then is the peritoneum, and middle part is the diaphragm muscle. Once you see this mode where the M mode is applied on it, calculate and to note the diaphragm thickness at end inhalation as well as at the end exhalation. And the diaphragm thickening fraction formula is used to calculate the diaphragm fraction, where thickening fraction at the inspiration minus thickening fraction at the expiration divided by thickness at the end expiration into 100 gives us the diaphragm thickening fraction. And the thickening fraction of less than 29 was considered to be indicative of diaphragm dysfunction. And second parameter is diaphragm excursion, where we have used a curvilinear probe that is placed in the right subcostal area, just angle between the mid-clavicular line and the anterior axillary line. So on this, on B mode, a bright linear diaphragm is identified just below the liver. This is a linear hyperechoic line that is seen below the liver, that is the diaphragm. On identifying it, we usually place a M mode on the ultrasound, where we can see to this trough and trough pattern, and we can see note the measurement at end exhalation and end inhalation, and on subtracting it, we can get an diaphragmatic excursion. So diaphragm excursion less than 1 centimeter is considered to be abnormal and indicative of a diaphragmatic dysfunction. And third parameter is time to peak excursion. That is, it is from the duration from the onset of the inspiration to the peak diaphragmatic excursion. So all the anesthesia and intraoperative management, we followed the institutional protocol, and for the ventilator management, all patients were mechanically ventilated with volume control mechanical ventilation mode with ventilatory parameters with a tidal volume of 6 to 8 ml per kg and with respiratory rate adjusted to maintain end tidal carbon dioxide between 30 to 35 mmHg. And this is the flow chart. And this is a statistical analysis. Coming to the result, this shows the comparison of demographics between the donors and the recipients, where recipients were about aged between 46 years and aged of donors of aged between 32. And this is statistically significant. And most of our recipients were males, about 90%, whereas in females, in donors, they were about 58%, and males, they were about 42%. And in terms of height, weight, BMI, and smoking, there was no statistical difference noted between the donors and the recipients. Ma'am, statistical significance was not there, but there were smokers in both the groups.
Sorry?
008. So what
It
is the
was-
significance level?
0.05, ma'am. It was a 0.08. It was not. Yes, ma'am. On comparing the skeletal muscle indicators between the donors and recipient, we could see the skeletal muscle index in recipients about 28, and in donors it was 36, and it was statistically significant. And on distribution of sarcopenia in recipient, 92% of the recipients were sarcopenic. And on prevalence of the diaphragm dysfunction in recipients based on the diaphragmatic thickening fraction at T0, that is at the baseline, the recipient had about 88% of the diaphragmatic dysfunction, and the prevalence has increased about 96% at T1, that is after 30 minutes after extubation, and at T2 it has decreased to 94%. And in prevalence of diaphragmatic dysfunction in donors based on diaphragmatic thickening fraction, at baseline they had about 70%, and after 30 minutes after extubation, prevalence has increased to 78%, and at T2 it has decreased to 64%. So this is a bar diagram showing the comparison of diaphragm parameters at different time points, where we can see to this diaphragm thickening fraction from baseline, that is from T0 to T1, there is a statistical decrease in DTF, and followed by at T2 even there is a decrease in the DTF. And in terms of the DE, that is diaphragmatic excursion, there was a statistically significant decrease in DE, and at T2 also there is a slight increase in diaphragmatic excursion, but it was statistically significant. In terms of the time for peak excursion, there is a decrease in TI, but it has improved to the baseline levels. Yes, ma'am. Yes, ma'am. I'm using the question number. So from T0, there is a significant decrease in T1 at in terms of time for T expression, and at T2, this level has been reached to the baseline level. So this diagram shows the comparison of diaphragm diameter at different time points in recipients, where one could see the diaphragmatic thickening fraction. There is a decrease from 21 to 20 from baseline to the T1, that is after 30 minutes after extubation. And at T2, it still persisted low. It never reached the baseline values. But there is no difference noted in terms of diaphragm excursion or time for peak excursion. Peak excursion. So this again, the table shows the comparison of diaphragm parameters at different time points in donor and recipients. We could see that all parameters in terms of diaphragmatic thickening fraction, diaphragmatic excursion, and TI, the donors had a better preserved function or parameters compared to recipients, and the decrease is noted in both the groups in terms of all the three parameters, but the decrease in recipient was far significant from the donors. And at T2, the donors tend to reach to the baseline levels by the T2 level at T2 point, but recipients still persisted to have a low DTF and DI. So this is a diagram showing the correlation between the diaphragmatic parameters with the duration of the mechanical ventilation. We found no significant or correlation with it. And on comparison of diaphragmatic parameters based on the preoperative SITs, in terms of all these parameters was not found to be statistically significant. And this table shows the diaphragmatic parameter shows based on the hydrothorax severity, where we could see in DTF, that is diaphragmatic thickening fraction and diaphragmatic excursion, with increase in severity, there is a decrease in diaphragmatic thickening fraction as well as diaphragmatic excursion. It was found to be statistically significant. And on correlation between the L3SMI, that is sarcopenia, and diaphragmatic parameters, we could find that time for peak expression gave a positive correlation with a statistical significance of less than 0.01. And this is the correlation graph, that is scatter plot explaining the same. And this is the table showing the diagnostic performance of baseline parameters in predicting the sarcopenia, where we have seen to the DTF and DE, where they have found no correlation significant. The only novel marker is that TI0. It has found a positive correlation with an AUC of 98% and a cutoff of less than for 2.45 seconds, had a sensitivity of 100% and a specificity of 93%. This is the ROC curve depicting the same. So discussion, our incidence of diaphragmatic dysfunction was about 66% in recipients and 25% in donors. Recipient had actually significantly lower baseline diaphragmatic thickening fraction, diaphragm excursion, and time for peak excursion compared to donors. But post-extubation, both showed reduction in DTF, but donor recovered within 24 hours, while recipient diaphragmatic dysfunction remained impaired. So this 88% of the diaphragm dysfunction at baseline has increased to 96% over a period of 26 hours of mechanical ventilation. These findings of our study are consistent with Levine et al., who showed that controlled mechanical ventilation, even for 18 to 69 hours, induces diaphragmatic microfiber atrophy. This prevalence of diaphragmatic dysfunction and reduced this diaphragmatic dynamic parameters in recipient is consistent with this Sharma et al. Study, who reported that significant thinner diaphragms are noted in liver transplant recipients compared to healthy donors. But the donors, they had a better baseline diaphragmatic parameters in terms of all these DTF, DE, and TI than recipients, although the mean DTF was below the global diaphragmatic dysfunction cutoff of 29%, but it could be because of the ethnic variation. Timma et al., he has reported a lower normal DTF values that in younger Indian adults, that is about 24 to 28%, suggesting that this range is physiological rather than pathological. Even the similar study by Avinash et al., where he evaluated diaphragmatic excursion values of 0.8 in males and 1.8 in males and 1.6 in females, closing matching our donor cohort. This again tells that the donors, what we have seen DTF levels, it represents a normal ethnic variation rather than a true diaphragmatic dysfunction. So this study, our study, where we have evaluated healthy donors for a mechanical ventilation of 9 hours, we could see the diaphragm excursion has decreased about 25 to 30%, diaphragm thickening fraction by about 8%. But we can see the recovery timeline is only 24 hours, where we had seen a near complete recovery, indicating a transient and reversible diaphragmatic dysfunction. This is consistent with the two studies that is made by Yu et al. On lab coli patient, where they have been ventilated for 2 to 3 hours, the decrease in diaphragmatic excursion is about 22 to 31%, and they has noted a similar recovery by POD1, indicating a transient diaphragmatic dysfunction. Whereas in Kim et al., where they have been ventilated for 72 hours in hepatic lobectomy patient, the diaphragm excursion has been decreased to about 60%, but the partial recovery was noted by them by day 7. This could be because of the difference in the surgical techniques as well as in the pain management techniques. And coming to the diaphragmatic changes in the pleural effusion, our pattern study, we could see the diaphragmatic thickening fraction has decreased by about 43%, and decrease in diaphragmatic excursion is about 17%, with increase in severity of the pleural effusion. This indicates that worsening of the diaphragm function with increase in pleural effusion size. This is consistent with Azab et al., who have evaluated critically ill patients with pleural effusion, where they noted a similar decrease in diaphragmatic thickening fraction by 45% and about diaphragm excursion by 71%. And they commented that decline in diaphragmatic thickening fraction and diaphragm excursion increases with increase in effusion depth. And it is also correlating with the Bosage et al., where they have evaluated outpatients with large pleural effusions and noted that the decrease in diaphragmatic excursion is about 1 centimeter. And they also commented that large effusions can cause paradoxical movement. So the novel thing in our study is the significant correlation between the time for peak excursion and sarcopenia, indicating the shorter inspiratory times were associated with reduced skeletal mass. This suggests that bedside ultrasound can serve as a simple and reliable tool to identify sarcopenia even when CT-based assessment was not feasible. Although the two studies, Indumati et al. And Thirav et al., they have used this time for peak excursion only as a predictor of extubation or weaning, where they have taken a cutoff of 0.75 and 0.8 to predict the weaning. But our study, it has extended its clinical relevance by demonstrating it with a direct correlation association between the time for peak expression and the preoperative sarcopenia. So the strengths of the study, it is a prospective study comparing both recipients and donors, and we have used diaphragm dynamic ultrasound parameters rather than purely a diaphragm thickness, and we have assessed the diaphragm at multiple points so that it is easy to track recovery and persistence of the diaphragm dysfunction. And this is the only study which talks about the novel mark validation predicting sarcopenia. And the limitation, it has very small sample size, and we have evaluated only the right side of the diaphragm. And the direct assessment of the phrenic nerve function was not performed, and there is no definitive cutoff for the Indian population for diaphragmatic dysfunction, diaphragmatic thickening fraction, and there could be an inter-observer variability in ultrasound. So our study concludes that liver transplant recipient had an overall burden of diaphragm dysfunction with 88% of pre-existing diaphragmatic dysfunction and 66% of new onset diaphragm dysfunction compared to 70% and 25% respectively in donors. And donor diaphragm function showed a spontaneous recovery within 24 hours, confirming in its transient nature, whereas in recipients it persisted. And the time for peak inspiratory flow demonstrate the best correlation with the sarcopenia, establishing it as a promise and non-invasive bedside tool for early risk stratification. And our study highlights the need for future research to establish normal diaphragmatic thickening fraction values in Indian population.
Thank you.
Udit, your quick comment. I think we have just a couple of minutes here.
The problem, the main issue we faced in this basically is that we didn't had any cutoffs in Indian population. That was the main limitation of our study. So I think it will be a good study going forward to do a study in which we can identify a normal cutoff of diaphragmatic dysfunction in Indian population. Because if you see in this, we had almost 60 to 70% of the donors had diaphragmatic dysfunction, which there is no reason to be. So only the study which we could found was they mentioned that the cutoff will be low in Indian population for around 20 to 24%. So that is why we thought it could be rather physiological than pathological. So I think that was one of the main limitation of the study. And otherwise, sarcopenia, as we all know, is a very important contributor in the post-operative morbidity in all the patients undergoing liver transplant or weaning in the ICU. So I think there needs to be a new definition which includes sarcopenia. Weightage has to be given to sarcopenia. I mean, it is not given as much as we think.
Yeah, frailty as well. And
Good, Anil and Saiti. Very good, actually. Very nice work. I think this is a very important contribution to the literature because these things are not very well documented. They're not very well documented until now that how diaphragm behaves after mechanical ventilation. And that especially, because you've done the donor as well, because, most of the time we take phrenic in the donors. Because we need a cup of right hepatic vein in order to do the anastomosis. So phrenic is taken in most donors actually, right phrenic. So that is the important thing, that in spite of taking the nerve, you do get a recovery from the of the diaphragm within 24 hours. So that's one good, you should actually include in your methodology that phrenic vein is taken. So when you take phrenic vein, you're going to take the phrenic nerve most of the time. So that's an important documentation which should be there in the methodology as well. And the recipient wise, I think it's very important actually to understand this, because that can alter how we manage just after the operation. Good, well worked, well done.